Hey guys.
Hi.
For those of you who are in here right now, do, are you guys working on your paper okay? Because I haven't seen anything else from anyone yet. I've been waiting to see like history of the town and that kind of thing from everyone.
Yeah, I literally have one more paragraph for the rest of my history,
Okay.
about a page and a half, but then I can send it to you.
Yeah, I mean, just send me what you have so far. That's better than nothing.
Okay.
That way I can see you're on the right track. What about the other group?
Ours isn't in like paragraph form. We have it all done, but it's just still in bullet points.
Well, why don't you send it to me? Send me what you have.
Okay.
Okay. That way I know you're on the right track with what you're doing. Okay, so today we have two chapters to get through, and then we're gonna do like some group work and stuff after we go through these. So it's no big deal. It's like a case study kind of a thing, and we might do some practice questions. We'll see how it goes. All right, so the first thing we're going to go over is chapter 13. So this is infectious disease prevention and control. So let's see if I have that up somewhere. There we go. All right. So with this is talking about this person named Min. Um, so in it says Min is part of a team of public health nurses that specializes in surveillance, screening, and treatment of communicable diseases. So she's a public health nurse that works on that kind of stuff. She says, what I love best is that that's hard to pinpoint. I like being part of an emergency team called in to respond to unique cases. I feel like I may be helping to save not just one patient's life, but many if we can successfully diagnose, isolate, and contribute to a larger surveillance and response effort. Which that's cool. I could see that. So our objectives, for this chapter would be we're going to talk about impacts and threats of infectious diseases on our society. We're going to explain how the elements of epidemiology triangle interact to cause infectious diseases. And we're going to provide examples of infectious disease control interventions at the 3 levels of public health prevention. So that's kind of what we're doing. And there's a couple more here, but okay, so with historical and current perspectives. So early in the 20th century, our leading cause of death would have been respiratory stuff. So things like TB, anything respiratory related. And then also diarrheal diseases were major killers as well. So infectious diseases still are a leading cause of death in children worldwide. It's the second leading cause of death overall. So current things that we're really concerned about are things like HIV, pneumonias, and influenza, and then vancomycin resistant Staphylococcus aureus, and also methicillin resistant Staphylococcus aureus. And then not too long ago, we had an episode of SARS, that severe acute respiratory syndrome that we were all concerned about. So those are kind of some of the things that we're a little bit, concerned with now. Although MRSA is still largely a healthcare associated infection, a community associated form of the disease is becoming more common with outbreaks, frequently associated with school athletic programs and prison populations. So that's kind of a concern. All right, so when we talk about how diseases get transmitted, we have the agent, the host, and the environment that all kind of work together. And then it depends on how they get transmitted. So we'll talk about that in more detail on the coming slides. But so like your modes of transmission might be different. So maybe you transfer it, by contact, or maybe you transfer it by air. It just depends. And then this also talks about disease development and the disease spectrum. So when we talk about the epidemiologic triangle, this is what we're talking about here. So we have the host on one point, the agent, and the environment. They all work together here. So a change in any one of these things could cause disease transmission. So anyway, so if you have like a change in the environment, like say maybe there's a, I don't know, a change in temperature or something, that could cause you to get sick from something. Or I don't know, maybe the host has like a decreased immune system or something, and that causes them to get sick. So there's different things that can happen. All right, so here's our modes of transportation. So as we are thinking about how someone gets sick from different, things. So there's a vertical transmission. So this is passing the infection from parent to offspring, either through sperm, placenta, milk, or contact in the vaginal canal at birth. So that's vertical. Horizontal transmission is person-to-person spread of the infection through one or more of the following routes. So it could be direct or indirect contact. It could be airborne or vector-borne, or like common vehicles like that. And then the common vehicle, when we talk about that, that means the transportation of the infectious agent from the infected host to the susceptible host through like food or water or plasma or blood or something like that. So when we talk about vectors, vectors are things like arthropods, like ticks or mosquitoes. They can be invertebrates, like snails, that transmit the infectious agent by biting or depositing the infected material near the host. So when we talk about disease development, this is exposure to an infectious agent, and it does not always lead to an infection and vice versa. So even though you're exposed, it doesn't necessarily mean that you get it. Infection means that you have entry, development, and multiplication of the infectious agent inside the susceptible host. And then if you have the disease, this means it's a possible outcome of the infection. It may indicate physiologic dysfunction or pathologic reaction. Then a couple other things they talk about here. Incubation period. So this is the time period between being invaded by the infectious agent and the first appearance of signs and symptoms of the disease. So like if you're thinking about, I think in one of these chapters we talk about sexually transmitted disease infections and stuff. A lot of times when you have one of those sexually transmitted diseases, like you get it and then there's a time period where you don't have any symptoms at all. So a lot of times people will spread it without even realizing. So that's that incubation period. And then communicable period is the interval during which an infectious agent may be transferred directly or indirectly from an infected person to another person. So persons with infectious diseases may exhibit a broad spectrum of diseases that range from subclinical infection to severe and fatal. At the community level, the disease may occur in endemic, epidemic, and pandemic proportions. So let's talk about the difference between those. Endemic. This is the constant presence of a disease within a geographical area or a population. Epidemic. This is the occurrence of disease in a community or region in excess of normal expectancy. So like maybe you expect a certain amount of the flu to be in your community at a certain time of year, but now you have more than that. So now you're at epidemic levels. And then pandemic. This is an epidemic that occurs worldwide and affects large populations. So like currently with what we have with COVID-19, that's a pandemic because it's occurring all over the world. It's not just here. Okay, so when we talk about this horizontal transmission, um, you can, pass something from person to person. And typically, like when someone's sick with something, usually a lot of times it's contact. You get it through contact because people don't realize that, like, they touch their mouth or their face or their eyes so much, and then they spread it to other people because they may have it in, those types of fluids. All right, so there's 4 routes. We have direct and indirect contact, such as, through sex, that would be direct. And then indirect would be through objects like clothing, toys, and things like that that you might touch, indirectly. Excuse me. And then the common vehicle, this is the infected host. So the vehicle could be through, food or water or body fluids, whatever it is. And then the other routes would be airborne and vector-borne. Vector-borne means like through bugs like arthropods. All right, so when we talk vertical transmission, this is passing the infection from parent to offspring via sperm, placenta, milk, or contact with the vaginal canal at birth. All right, again, here's a question. So transmission of a disease via contact with an infected person's saliva is an example of what mode of transmission? It's going to be common vehicle transmission. D. All right, and again, transmission of a disease via contact with an infected person's saliva is that common vehicle transmission. All right, so with disease development, exposure to an infectious agent does not always lead to an infection. We talked about that before. For example, like say you've been exposed to TB. There's all kinds of people out there who have been exposed to that, but they may not get an active form of that for a while. So it doesn't mean that you have TB at the time if you've just been exposed to it. All right, so this slide is talking about to be infected with something, you have to have an entry point to get into that, that vector, that body, and development of an agent in a host. So once the infection gets into your body, it has to like multiply and do its thing in there. For you to get the disease, you end up having some physiologic symptoms. So you actually have, signs and symptoms of this to know that you have it. And we talked about the incubation period being that time between invasion and first signs and symptoms. And then the communicable period being the interval in which the agent can be transferred from one person to another. Okay, so with the disease spectrum, so this can be broad. Sometimes the disease is not very bad, and then sometimes it's super bad. And we see that currently with COVID-19. We see that some people get it and they don't even, they can be asymptomatic. They don't have any symptoms. And then there's other people who get it really bad where they end up in ICU on a ventilator. So there's a wide variety of things that we see with the disease. So again, I would definitely make sure you know the difference between endemic, epidemic, and pandemic. So with endemic, it's a constant presence of a disease in one group. An epidemic is occurrence beyond normal expectancy in one region or community. And then pandemic is an epidemic, so it's a type of that, but it occurs worldwide and it affects really large populations of people. All right, so with surveillance of communicable diseases, what do you think are some things that we do to kind of keep an eye on some of these infectious diseases that we have going on? What do we do for surveillance? Anyone have a thought?
I mean, obviously, like we're reporting to the CDC, so we're probably keeping an eye on like what's arising in certain populations or if it's spreading. You know, what I'm saying, in the standpoint of a specific disease.
Okay. So like if you're work like say you work at the hospital somewhere and someone comes in and they have TB, who are you supposed to report that to?
The health department, or like,
Yes.
yeah.
Yes. So pretty much local health departments really like kind of get a lot of that data there. And then like, you know, for bigger things like with what we have going on with COVID-19 right now, they probably, you know, like you report it to the local health department and they probably in turn report it, you know, on up the chain. So everyone else gets the data as well. So yeah, that's a big thing. So reporting things is huge because then you can keep track on, you know, how bad it is at the time, right? And then this talks about surveillance of agents of bioterrorism, which that's so scary to me. It's just bioterrorism, these things that we don't see very often. Like, you know, back, I forget how many years ago that was when people used to be sending like letters with anthrax in it to people to try and, you know, get them, you know, with that white powder and everything. That's just crazy to me that to think that you could have stuff like that going on. But yeah, there's surveillance of those types of things too, because we need to know, you know, how many cases of those there are, because we need to know, be able to have a treatment plan for them, to be able to have a vaccine and medicines to treat those things. If we didn't, then we'd be up the creek, you know. So yeah, there are a certain list of reportable things that your local health department is going to want you to report. Okay, so this is talking about, again, some of those same things. So when you do surveillance, you're just gathering the data. So you want to know who has it, when they got it, where this was at, and what exactly it was. These elements are used to answer the why. So a good surveillance system collects, organizes, and analyzes current, accurate, and complete data for defined disease conditions. The resulting information is promptly released to those who need it for effective planning, implementation, and evaluation of disease prevention and control programs. So I guess in your book there's a box in this chapter, box 13-2, that talks about a list of 10 commonly used data elements that you would use to help you with surveillance. So with bioterrorism, since 9/11, there's been an increased emphasis on this, so that you can look for any disease that might be associated with intentional release of a biologic agent. Syndrome surveillance. So this would be like if people have certain signs and symptoms, you would want to report that, you know, because maybe that might mean that there's a certain thing going on. So with this, you incorporate factors like temporal and geographic clustering and usual age distributions. You also look at what types of symptoms they're having. Things like flaccid paralysis, respiratory signs, skin rashes, GI symptoms, anything like that. So the goal is detecting things early so that it doesn't result in some kind of big scale bioterrorism attack. So some examples they give here. So tracking emergency room visits. So that would be one way to surveil this. Tracking absences at school. And then sales of over-the-counter medicines. So like if someone's getting a rash from something all the time and they constantly are going to the store buying, you know, rash cream for this, then that would be a way you could surveil this. So as far as the reportable diseases, there is an actual national notifiable disease surveillance system. So there's a database that keeps track of this stuff. So a notifiable disease is one which regular, frequent, and timely information regarding the individual case is considered necessary for the prevention and control of the disease. So that's kind of what something would be reportable. Okay, so emerging infectious diseases are those in which the incidence has actually increased in the past several decades or has the potential to increase in the near future. It may be new or known infectious diseases. So here's some emerging factors that might affect that. So could be a societal event, healthcare, food production, human behavior, environmental things, public health, or even microbial adaptation. All right, and then this gives an actual map of the world here, and it says, here's some examples of emerging diseases. So like you can see here, cholera. So there's a place here in Africa, and there's also a place here in South America where that's a big problem. Yellow fever is another one, same thing. Look at this, multi-drug resistant malaria. That's kind of scary. So there's certain things that, are emerging that you would need to really keep good surveillance on. Okay, so to prevent, control these diseases, we want to do some different interventions, right? So we talk about primary, secondary, and tertiary prevention to try and help prevent these things from happening. So our role is big in prevention to try and keep these things from becoming a problem. And it helps if we do a multi-system approach, to include everyone and not just nursing, but other, groups of people as well to help make this happen. So again, our goal is to reduce prevalence of a disease. So we try to do some prevention things. So this would be things like immunizations, that surveillance we were just talking about, different teaching things, screening and treatments. And then the multi-system approach to control is the imbalance between human host and the environment. So the goal of prevention and control programs is to reduce this prevalence of disease to a level at which it no longer poses a major public health problem. In some cases, diseases may even be eliminated or eradicated. So then this gets into a little bit about agents of bioterrorism. So remember I mentioned anthrax a few minutes ago. So this is an acute disease caused by a spore-forming bacterium called Bacillus anthracis, I guess. This may manifest in one of three syndromes. So it can be skin, cutaneous, gastrointestinal, and respiratory or inhaled. Then you've got smallpox, which that used to be a thing back in the day, but now it's like an actual bioterrorism agent. So the last known natural case in the United States was in 1949. The last case worldwide was in 1977. If someone had this and they tried to release it as an agent of bioterrorism, it says susceptibility is 100% in unvaccinated people. So those vaccinated before 1982 are not considered protected, although they may have a little bit of immunity. And the fatality rate is estimated at 20 to 40% or higher. So that's kind of scary. Many healthcare providers may not identify diseases because many have not seen smallpox. There is a vaccine available since 2007, but not recommended for the general public. So, yeah, at least we have a vaccine. That's good to know. And then there's the plague. This is a vector-borne disease that's transmitted by rodents or fleas on rodents carrying this certain this bug. Fewer than 20 cases per year since 1970 in the United States, so that's good. And initial signs and symptoms are really non-specific, so you could have myalgia, malaise, fever, chills, sore throat, and headache. So how would you figure out this is the plague? That's kind of crazy. So yeah, it might be kind of difficult to pick that out. And then there's another one called tularemia. This is sometimes referred to as rabbit fever or deer fly fever. So it's a zoonotic disease caused by the bacterial agent Francisella tulaneris, which is carried commonly by wild animals, especially rabbits, as well as muskrats, voles, beavers, and some domestic animals. This has been reported from every state except Hawaii, but it's not a particularly common disease, so maybe only 120 to 130 cases a year of this are documented. All right, and then there's also vaccine preventable diseases. So this would be stuff like measles and rubella and pertussis, influenza. So the Advisory Committee on Immunization Practices, the American Academy of Pediatrics, and also the American Academy of Family Physicians regularly update recommended immunization schedules. So for measles, they say it's an acute, highly contagious disease that, although considered a childhood illness, may be seen in the United States in adolescents and young adults. These recent outbreaks in the U.S. highlight the ongoing risk of measles from other countries from people who travel. Rubella is also called the German measles. This causes a mild febrile disease with enlarged lymph nodes and a fine pink rash that's often difficult to distinguish from measles or a scarlet fever. So the way that it makes it different from measles is rubella is the only moderately contagious illness. So it's kind of a little bit more contagious. In 1941, the link between maternal rubella and poor pregnancy outcomes was recognized, and the disease suddenly assumed major public health significance. With pertussis, this is also called whooping cough. This begins as a mild upper respiratory tract infection that progresses to an irritating cough that within 1 to 2 weeks may become paroxysmal, which means it's a series of repeated violent coughs. Because of its cyclic nature, there are periodic outbreaks of pertussis. And then we're all familiar with influenza. So this is a viral respiratory tract infection that's often indistinguishable from the common cold or other respiratory diseases. There's 3 types. So we have A, B, and C. H1N1 is a type of influenza A, which that was really popular back in 2009. And then, of course, we have these flu shot campaigns where we try to get people to go and get the flu shot so we don't have these big outbreaks of these things. And then, back in 1997, we had the avian flu, that influenza A. All right, so there's also foodborne and waterborne diseases. So FoodNet is a CDC Sentinel surveillance system that targets 10 sites across the country and collects information from laboratories on diseases that cause enteric pathogens transmitted commonly through food. So, telling people how to, safely prepare food is really important, because I think a lot of people do that wrong out there. You'll see a ton of people as you're practicing as a nurse who have like E. coli in their urine or something like that. There's so many things that we get that we don't even realize because we're not handling our food or water correctly. So the CDC estimates that in the U.S., as many as 76 million illnesses, 325,000 hospitalizations, and 5,000 deaths occur from foodborne illnesses each year. Most the result of unidentified agents. Of the estimated 14 million illnesses in which a pathogen is identified, Salmonella and Campylobacter are most frequently implicated. Okay, so vector-borne diseases refer to illnesses for which the infectious agent is transmitted by a carrier or vector, usually an arthropod, like a mosquito, a tick, or a fly, either biologically or mechanically. So with biological transmission, the vector is necessary for the developmental stage of the infectious agent. Examples include mosquitoes that carry West Nile virus and fleas that transmit the plague. So on this slide, it talks about, Lyme disease, Rocky Mountain spotted fever, and tick-borne things. So Lyme disease is pretty crazy. People can get that super easily, just by getting a tick on them from being outside. And it's really hard to diagnose. A lot of people don't realize that that's what's wrong with them because their symptoms are really vague. Usually this occurs in the summer in certain areas. It's only in certain areas that it's more common. And then the Rocky Mountain spotted fever, this occurs in the southeast, in Oklahoma, Kansas, and Missouri. And then, of course, the tick-borne diseases are, we always want to try to make sure that if you're going to be outside for a while, you tell your patients to make sure they check their hair when they come inside so they don't see any ticks in there. And try and, talk about prevention things. Okay, so diseases of travelers. So this is where they get into a little bit about malaria, food and water diseases, and diarrheal disease. So individuals traveling outside the U.S. need to be aware of and take precautions against potential diseases to which they may be exposed. Which diseases and what precautions depend on the individual's health status, their travel destination, and the reason for the length of the travel. Persons who plan to travel in remote regions for an extended period may need to consider rare diseases and take special precautions that would not apply to the average traveler. On return from visiting exotic places, travelers may bring back with them unplanned souvenir in the form of a disease. Therefore, in a presenting client, it's important to ask the history of the travel. All right. So a zoonosis is an infection that's transmitted from a vertebrate animal to a human under natural conditions. The agents that cause zoonosis do not need humans to maintain their life cycles. Infected humans have simply managed somehow to get in their way. The means of transmission include animal bites, like bats and rabies, inhalation, rodent excrement and hantavirus, and then also ingestion, like through milk or something else. Direct contact, like rabbit carcasses and tularemia, and arthropod intermediates. So that's kind of how that gets passed. And I believe our COVID-19 kind of has this in its background, this zoonosis. All right, with parasitic diseases. Parasites are organisms that depend on a host to survive. So endoparasites, those that live within the body, are classified into 4 major groups. So we've got roundworms, tapeworms, flukes, and protozoa. Yuck. Nematodes, cestatodes, and trematodes are all referred to as helminths, along with, I can't say these words, or thorny-headed worms, which are not as commonly involved in human infections. All right, so with these intestinal parasitic infections, typically you don't see those a ton around here, but they're in greater concern in developing countries. Pinworms are the most common helminthic infection in the United States, so usually in schools or institutions of overcrowding, you'd see something like that. Parasitic opportunistic infections would be, more prevalent in people who are immunocompromised, so maybe like someone who has HIV or something. And then with all of these types of diseases, we want to try to diagnose it early and talk about improved hygiene and vector control, and really give some good education about how to prevent some of these sicknesses from happening. All right, and then there's healthcare associated infections. So this is transmitted or developed within a hospital or other healthcare setting. So like this would be if you come into the hospital for something totally unrelated, and then you end up going home with something else that you didn't come in for. So like you got pneumonia in addition to something else that you came in for. So typically you're going to develop symptoms within 48 hours after you get admitted. So this can, be transmitted through healthcare workers, visitors, other patients. It could be anyone who has had contact with this person in the hospital. So, of course, we always want to do universal precautions. We started this because of the HIV transmissions during healthcare procedures back in the 80s. It's hard to believe it's only been that long that we've been doing universal precautions. The CDC recommends this for all healthcare settings. And remember, when you talk about universal precautions, you're talking just basic precautions. It's nothing like, gowning up or anything for every person that you see. But you're definitely making sure that you wash your hands really good. Obviously, if this person that you're dealing with is coughing or doing something like that, you could take other precautions. You could put a mask or something on to prevent, something from being transmitted. Okay, so then again, this comes back to this MIN person. So it says, I can't see myself shifting to any other role in public health nursing. The combination of surveillance and reporting keeps me in collaboration with the larger public health system while responding to our particular patients in crisis is the right balance for me. And when we succeed in not only saving a patient but reducing prevalence of a deadly communicable disease, there's nothing more rewarding. So how nice. All right, so that is chapter 13. Before I go on to chapter 14, let me see if I can pull up some questions we could do. So I can get on the right thing here. Let's see if I can share this. Okay, so these are those questions that I've been sending you guys the past couple of weeks. So I'll do that again, for today. But this is, we'll just do a couple of them. This is for chapter 13. So let's look at number 2. A 6-year-old is brought to the emergency department with a full body rash and fever. During the nursing assessment, which of the following findings would be most relevant to recognizing the case as potential smallpox rather than varicella? So look at your options here. What do you guys think? Anyone have a guess?
D.
What's that?
D.
D, you said? Let's see. They're saying B. So the fever has responded to acetaminophen and the child is playful when the temperature is not elevated. So they say smallpox is associated with a sudden onset of fever. So you have the fever, the body aches, and occasional abdominal pain and vomiting, just like you would with influenza. So the rash, which is centrifugal with same stage lesions in all areas, but most abundant on the face and the extremities following 2 to 4 days after the fever begins decreasing. So with chickenpox, the rash is different. So the lesions are most abundant on the trunk or in areas covered by clothing. So the rash is present at the onset of symptoms. So that's kind of how it's a little bit. All right, let's look at this one. So, a school nurse notes that 60 children have missed days of high school because of pertussis this past year, and this rate has been relatively constant for the past 5 years. The nurse plans to work with community to increase awareness of the seriousness of the disease for children younger than 6 months of age, and to raise and maintain the immunization rates because in this community, the pertussis is, so is it endemic, epidemic, pandemic? Can I see that last word? Or sporadic?
A.
Yes, it is A. Good job. All right, let's try this one. So the World Health Organization develops the Five Keys to Safer Food campaign in 2001 to address the problem of foodborne and waterborne diarrheal diseases worldwide. This campaign emphasizes which of the following practices?
A.
Yeah, I would think it would be A. All right, let's try this one. An American takes a long-awaited vacation in sunny Mexico. Boy, wouldn't that be nice? Spending days on the beach eating fresh raspberries from a nearby vendor and drinking bottled water. The tourist may be altering what?
A.
It is A. Good job. All right, let's see. Let's try this one. An example of secondary prevention of infectious disease is what?
Maybe C.
It is C. Look at you guys. That's good. So remember, when you're talking primary, secondary, tertiary, primary is usually you're trying to prevent it from happening altogether. So that's usually like immunizations and stuff. Secondary, typically, maybe they already have something going on, but you're trying to make it better so it's not going to get worse. Like you're doing something to make it so it doesn't get any worse. So, like that would fit here with the quarantine. And then tertiary, what's an example of that? What would you be doing with tertiary? Usually tertiary is always like has something to do with rehab. So look down here, it says tertiary prevention interventions reduce the complications and disabilities of disease through treatment and rehab. So that's kind of how I want you to think of those three things. All right, let's try one more. Okay, in an effort to address West Nile virus, a community increased livestock immunization, began a vector control program, and initiated a community campaign to eliminate standing water reservoirs. This best exemplifies communicable disease control through what?
B.
It is B. Good job. All right, so anyway, I'll send you guys this later. I just thought we'd deal with you as we go. Okay, let me pull up our other one here. All right, so this one is talking about communicable and infectious disease risks. So in this chapter, we are going to describe the natural history of HIV infection and appropriate client education at each stage. We're going to talk about clinical signs of selected communicable diseases. I think they mentioned some stuff about hepatitis, tuberculosis, STDs in here. And then we're also going to analyze behaviors that place people at risk for contracting selected communicable diseases, and then explain the various roles of nurses in providing care for those selected communicable diseases. So some of those things. Okay, so let's talk a little bit about HIV. So remember, HIV started to come about back in the 80s, believe it or not. So this is, transmitted through, blood or body fluids. So back when it first came about, people were always really scared if you knew anyone with HIV, because you just didn't have good education about it, and people thought that you could just like touch someone and get it from them. So no one wanted to be around someone like that. And, people were kind of ostracized. So, now that we know some more about it, they actually, surveil this. They do some surveillance. We do a lot of HIV testing now, and we try to reduce risks of the spreading now that we know more. So, like before, it wasn't clear that you could, pass HIV to a baby, through the birth canal. We didn't know that. So now we know, so we can treat people better and kind of be prepared for what could come, So like with perinatal and pediatric HIV infection, I mean, horrible, right? If someone gets it when they're young like that. So there are a lot of resources out there for people now, so they have a lot better information about this disease process. So really with HIV, there's 3 stages of infection. You have the primary infection, where you get infected with the HIV. This is within about a month of contracting the virus. During this time, a lot of times people don't have a whole lot of symptoms, and if they do, it's just like flu-like symptoms. So you don't think anything of it. You may not think there's anything wrong. Then there's a clinical latency. So this is when again, maybe you don't show any symptoms, so you think you're fine, and you have it, and you're spreading it around to people because you don't realize. So this talks about the use of highly active antiretroviral therapy. This has greatly increased survival time of people with HIV and AIDS. Now that we know more about this and we have all of these new drugs, when people take this totally helps. Like, you could not have taken anything for your HIV for years, and then all of a sudden, if you start taking this, even then, it still gives you some protection. Obviously, if you took it way, earlier on, you would have better results. But even if you take it later on in your infection, it still helps you. So those are good things. And then this talks about symptomatic disease when you actually have full-blown AIDS. So at this point, now our CD4 count is going to be less than 200, and we also have a documented HIV infection, like some kind of opportunistic infection that happened in addition. So just to review, I don't know if you guys remember very much about HIV or not, but basically what happens is it's a virus that gets into your body, just like what we were talking about in that last chapter. Once it gets into your body, it sets shop there. It sets up shop, and it replicates. And so, like, you may have like one HIV cell that comes into your body, and then it just multiplies and multiplies, and then you end up having millions of them inside your body. It's just ridiculous how fast they multiply. So the problem with viruses is that they're constantly mutating and changing. So it's really hard to come up with some type of way to treat them. So anyway, with HIV, what happens is that virus in your body, it attacks those good cells that you have, those CD4 cells. CD4 cells are cells that would normally go and attack something that's foreign in your body to like keep you safe so you don't get sick. So it's kind of like your immune system, basically, your CD4 cells. So what happens then with HIV is HIV attacks those cells, so you have less and less of those good CD4 cells to fight off any infection. So your immune system like goes down dramatically, you know, when you have HIV. So typically with these different stages of HIV, like you can have stage 1 or stage 2, and your CD4 count might be kind of okay, but still, you know, a little bit lower. But then once you hit that stage 3, that full-blown AIDS stage, that's when that CD4 count starts to get really low. So it's less than 200. So you don't have too many of those good cells left now. And so that's why that last stage is associated with that opportunistic infection, because then you can get pretty much any type of bug and you just can't fight it off because you don't have enough of those good cells anymore. So like I could get just your basic run-of-the-mill pneumonia and it could kill me because of that, you know? So let me see if I see anything down here at the bottom. Oh, they put some examples of different AIDS-related opportunistic infections. There's a ton of them if you really looked into this. So they have this pneumocystic pneumonia, that's pretty common. They have oral candidus, so that's your basic thrush and you know some other things going on. TB is a big one in HIV. Invasive cervical cancer, recurrent pneumonia, those are all examples of opportunistic infections. So again, this is transmitted through exposure to blood, semen, transplanted organs, vaginal secretions, and breast milk. Those who have had blood, sexual, or needle sharing exposure with an HIV infected person are at risk of contracting the virus. And again, remember what I said before, people years ago used to be really worried that just by, you know, touching someone with AIDS, you were going to get it, but that's not true. It's not, you know, through casual contact. Okay, so like I said, the first cases of this were identified back in the early 80s, they say 1981. So 35.3 million people live with HIV infection. Sub-Saharan African, excuse me, Africa accounts for more than 70% of all HIV infections. Epidemic also growing in Central Asia, Middle East, and Eastern Europe, so it's getting worse over there now. So the treatment for HIV infection has been given higher priority, and the prevalence of AIDS has increased. So that's kind of sad to know that that is increasing. Yeah. So anyway, now that we have this medication, if you can identify who has HIV and you can get them to get on the medication, they have way better chances of increasing their survival rates. Once you're on the medication, it actually will help your CD4 count go up, and it'll make that viral count in your body, all of those individual viruses that are multiplying, it'll make those go down. And so you'll feel a ton better when you're on this medication. So in 2008, we started doing confidential reporting of HIV positive status by name. This is required in all 50 states and the District of Columbia. And then with HIV testing, there's a ton of different ways you can get an HIV test. It didn't used to be that easy, but now it is. So there is an HIV antibody test. This will indicate the presence of an antibody to HIV. And there's a couple different names for it that you might see it written like. You see how this is called enzyme-linked immunosorbent assay. So EIA. I have also seen it written as ELISA, E-L-I-S-S-A. So that's another one that's an antibody HIV test. So it screens the blood and other donor products, and this does not reveal whether the individual has symptomatic AIDS, nor does it isolate the virus. It just says if you have it or So if you were testing someone for this, you would do that antibody test first, and then if it comes back positive, then you would go and move on to the Western blot. The Western blot is going to be your second test that you do, and that's going to confirm if that antibody test was correct or not. So it minimizes false positive results because sometimes people are worried about that. So routine testing is recommended for all clients attending health departments, STD clinics, family planning clinics, community health centers, and primary care offices. Voluntary screening programs for HIV may be either confidential or anonymous. The process for each is unique. All right, and then when we talk about perinatal transmission, so this accounts for nearly all HIV infection in children and can occur during pregnancy, labor and delivery, or breastfeeding. So if you can imagine, you're passing this through blood and body fluids. So if your baby is breastfeeding, they're going to get it through your breast milk. So the recommendation is to make HIV testing a routine part of prenatal care. And then with pediatric infection, despite having an HIV-infected mother, many children do not acquire HIV or AIDS, which is great. You would hope none of them would. However, one or both parents may die, and this indirectly affects the health of the child. So if you lose a parent because of this, then what's going to happen to the kid, So the effectiveness of antiretroviral therapy in pregnant women and newborns is preventing transmission from mother to fetus or infant has made pediatric HIV rates decline sharply, which is great. Okay, so HIV stage 3. So this is when we have someone with full-blown AIDS in the community. So this is a chronic disease. Much care is provided in the home. So we need to provide teaching to the patient and the family. Try to get them to stick with their medications. This is highly, this is their medication. I forget what it stands for now. Highly something retroactive. I forget. Anyway, it's really important that they stay on the medication. A lot of times the medications will cause a lot of crazy side effects. So sometimes people will try to go off of them because of that, which is not a good idea. And then other times it's because they cost too much and they can't afford them. There's a lot of reasons why people don't take them. If you can imagine, a lot of people, there's a real big stigma against people with HIV and AIDS. It's a little bit better now than it used to be, but it used to be really bad. So a lot of times people will just quit taking their meds because they're so depressed, or if they start drinking or taking drugs or whatever because they're so depressed about what's happening to them. All right, the Americans with Disability Act of 1990 and other laws protect persons with asymptomatic HIV infections and AIDS against discrimination in housing, at work, and in other public situations. Mental health issues such as depression and substance abuse and bipolar disorder are often present in someone newly diagnosed with HIV. These conditions must be addressed prior to or simultaneously with HIV treatment to be effective. HIV-infected children should attend school because the benefit of attendance outweighs the risk of transmitting or acquiring infections. So they definitely should still be going to school. All right, so what's the greatest challenge raised by allowing children infected with HIV to attend school? It's going to be these children are more likely to develop complications from childhood diseases. So you could see that because if they have HIV and they're going to school, anyone that goes to school, you pick up everything from all these people that you're around at school. They already have a low immune system, so they could get sick really easily. So that would be something to think about. All right, and this is just a review here. HIV-infected children should attend school. This says, no case of HIV infection in the United States has been transmitted in a school setting. So instead, because of impaired immunity, children with HIV infection are more likely to get childhood diseases and suffer serious sequelae. Okay, so then another thing that we can do as nurses is we can give people resources to help support them in their illness that they have. So there's different service organizations that are voluntary or faith-based that might help them, you know, if they're in need of certain things. And then you can give them toll-free numbers and websites that also can help them if they're having problems with their disease process. Okay, so then this starts getting into sexually transmitted diseases. So there's a few that we're going to go through here. So gonorrhea, syphilis, chlamydia, genital herpes, and human papillovirus infection. So the number of new cases of STDs continues to increase. Chlamydia is the most commonly reported infectious disease. Gonorrhea is the second most common. Because of the impact of STDs on long-term health and the emergence of 8 new STDs since 1980, continued attention to their prevention and treatment is vital. Oh, that's kind of sad. All right, so with gonorrhea, this is a bacterium that infects mucous membranes of the genitourinary tract, the rectum, and the pharynx. Transmission is genital to genital contact, oral to genital contact, and also anal to genital contact. You have uncomplicated versus complicated gonorrhea. Uncomplicated means that it's limited to cervical or urethral infection. Complicated means that you have worse things going on. So you can have salpingitis, epididymis, systemic gonococcal infection, and gonococcal meningitis. So that's pretty bad. So the highest incidence of gonorrhea is in the United States is among African Americans, persons in the South, and women 15 to 24 years of age. So there's also a number of antibiotic resistance cases of this that's on the rise. They said there's a penicillin-resistant gonorrhea that was first identified in 1976. By 1990, 64,972 resistant cases were reported. So antibiotic resistance has continued to develop exponentially, with gonorrhea becoming resistant to every antibiotic used for treatment. In 2012, the CDC revised its treatment guidelines and no longer recommended oral cephalosporins as a recommended first-line treatment for gonorrhea, in an effort to preserve the last remaining treatment option. At this time, combination therapy of ceftriaxone IM, along with either oral doxycycline or azithromycin, is the most reliably effective treatment for complicated gonorrhea. The injection route versus the previously recommended oral may take treatment more challenging, or it may make treatment more challenging due to patient fear of injection and healthcare facilities having to stock injectable medications. Increasing cases attributed is part to indiscriminate or illicit use of antibiotics as prophylactic by persons with multiple sexual partners. So yeah, it's, you know, when we get these sexually transmitted infections, if you're constantly going and getting an antibiotic every time you turn around, then you're going to have, you know, something that is resistant to things. So it's kind of scary. All right, with syphilis, so this is someone who gets infected with this specific, I can't say it, treponema spirochete. It infects moist mucous or cutaneous membranes. Usually you would get it through direct contact, sexual contact, or mother to fetus, or through a blood transfusion. Highest rates of this would be men having sex with men. Recently, a number of infected women have increased as well. So there are different clinical signs. You have primary, secondary, and tertiary, and then there's also congenital syphilis. Congenital syphilis is transmitted transplacentally, and if untreated, can cause premature stillbirth, blindness, deafness, facial abnormalities, crippling, or death. All right, and remember we said chlamydia was one of the most popular ones that you see now. So this is a bacterium that infects the genitourinary tract and rectum of adults. It can cause conjunctivitis and pneumonia in neonates, and its transmission is through mucous membrane contact with mucopurulent discharge from an infected site. It's the most common reportable infectious disease. If you don't treat it, it can result in pelvic inflammatory disease. Genital herpes is another concern. Herpes simplex virus 1 and 2. This is the majority of cases of genital herpes is going to be from herpes simplex virus 2. There's also an increasing number of cases caused by, herpes simplex virus 1. There is not a cure for this, but with transmission, it's from direct exposure. It infects genitalia and the skin. With HSV2, 16.2% of American adolescents have this, of particular concern to women and children, of course. And then it's linked with development of cervical cancer and its increased risk for fatal newborn infection. And then in my other class that we were talking about this, and we were saying that a lot of times people think when they clear up their, like say they have genital warts or something, if they clear up those warts, they're like, oh, I'm good now. I can't infect anyone anymore. But that's not the case. When you have this, you have it for life. So you can still spread it to other people. All right, and then HPV. So HPV genital warts. So you can get this on the mouth, the genitals, and the anus. Direct contact with HPV-associated warts. Actually, this is what I'm talking about here, not the last one. And then FDA-licensed vaccines. There are some for it. And then complications, again, it's linked to cervical cancer, and then other cancers, vaginal, anal, and oropharyngeal. All right, this also gets into a little bit about hepatitis. And if you remember back to when you talked about hepatitis before, hepatitis is just like inflammation of your liver. So there's 3 million different kinds of hepatitis. And, you can get it multiple different ways. So on this slide, it's talking about A, B, and C. And then there's also non-ABC hepatitis, which we'll get into that in a minute. Viral hepatitis is going to refer to a group of infections that primarily affects the liver. These infections have similar clinical presentations, but different causes and characteristics. So it's definitely, beneficial to know the difference between some of these. So when you talk about A, hepatitis A is, you're going to get this through fecal oral route. So like you could be, down in Mexico on a vacation, and you could, have messed up water. So you could get it from that. Or you could eat something that wasn't cooked right, or maybe someone didn't wash their hands when they went to the bathroom and then they made your food, So it could be from anything like that. So with this, you basically get GI types of symptoms, and it kind of works itself out. It's just like when you would have an episode of the flu or something at home, like a vomiting type of a flu, it would be just like that. So there is a vaccine that's available for this since 1995. The incidence of this has declined 92%, which makes it completely preventable. So for the vaccine, you definitely would want to give it to someone who, might be immunely compromised or something. That might be helpful so that they don't get it. Down here at the bottom, it says travelers to countries with high rates of the disease. Like if you're going somewhere that you might get hepatitis A, definitely get the vaccine. Children living in areas with high rates of it, they should get it. IV drug users, persons with clotting disorders or chronic liver disease. Any of those people should be getting it to try and help. Now, hepatitis A, I don't know if any of you have had that before, but it's a two-step shot. So you have to get both steps to be able to have good immunity from this. Now, if you did get this, like say you went to a country and you ended up with this, there is an immunoglobulin that you could take that kind of will help cut down your sickness time a little bit so that you don't get this anymore. All right, there is also hepatitis B. So we all should know about that because we all had to get our hepatitis B shots just to be in nursing. So this is spread through blood and body fluids. It remains alive outside the body for at least a week. So you have acute and chronic forms of this infection. There is a vaccine, like we all know, because we all had to have it. And when we talk about high-risk groups, so users of injection drugs, persons with STDs or multiple sex partners, immigrants or refugees or their descendants who came from areas of high endemic rates of this, healthcare workers, clients on hemodialysis, inmates of long-term correctional institutions would be high-risk groups for this. The acute infection is self-limiting, so that means if you get this, it would like work itself out, I guess you could say. Individuals develop an antibody to the virus and successfully eliminate it from the body, so it's just a short-term thing and you're done. However, there is, and it says they subsequently have lifelong immunity towards it then after they get it. But then chronically infected people are unable to get rid of it, and it remains like they are a lifelong carrier of it. As carriers, they can transmit this to others. They may develop hepatic carcinoma or chronic active hepatitis as well. So the Occupational Safety and Health Administration regulations say that it mandates specific activities to prevent workers from getting this and other bloodborne pathogens. It requires employers to identify the risk of blood exposure to various employees. If employees perform work that involves a potential exposure to other body fluids, employers are mandated to offer the HPV vaccine to an employee at the employer's expense and to offer annual education programs on preventing this. Employees have the right to refuse the vaccine. Then when we talk about hepatitis C, so this is the most common chronic bloodborne infection in the United States. You can get this through blood and body fluids as well. And then with high-risk groups for this would be healthcare workers, emergency personnel who are accidentally exposed, infants who are born to infected mothers, injection drug users, particularly those who share needles, and anyone born between 1945 and 1965 is at higher risk. So this spread rapidly during the 1980s, and this can cause, I guess you could say this is a chronic liver disease. So it's the 12th leading cause of death in adults in the United States, and it's the most common reason for needing a liver transplant because over time it just messes your liver up. It won't work good anymore at all. All right, and then remember we said there's non-ABC hepatitis forms as well. So like I said, there's 3 million different kinds, but for this group, there's hepatitis D, E, and G. So D, there is a chronic and an acute form. It only occurs in those already infected with hepatitis B. So it kind of goes along with hepatitis B. E, there's only an acute infection, and it's transmitted by fecal oral route, so it's very similar to A. And there's no vaccine for that one. And then G, this does not cause acute or chronic hepatitis, but the virus has been isolated in patients with post-transfusion hepatitis. So that's another kind. All right, this also talks about tuberculosis. So remember, TB is going to be transmitted through the air, so it's airborne. Typically, you're going to have, once you have it and you have the active form of it, you are going to have specific symptoms that are different compared to anything else. So like the cough that you have is going to last for weeks. Like maybe you've had it for 3-4 weeks, you just can't get rid of it. You're coughing up blood. You typically have night sweats, fever, fatigue, weight loss, all this stuff going on. So the World Health Organization reports 12 million cases in 2012 and 1.3 million deaths due to TB. And there's also a drug-resistant form of it as well. So transmission usually occurs through exposure to the tuberculous bacilli and airborne droplets from persons with pulmonary tuberculosis who talk, cough, or sneeze. So Southeast Asia and Western Pacific regions account for 58% of TB cases. Africa accounts for 25%. In the US, half of the new cases are in New York, Florida, Texas, and California, so they're in the bigger states. With the drug-resistant TB, multi-drug-resistant TB is resistant to rifampin and isoniazid. Extremely drug-resistant TB, it says it's added resistance to fluoroquinolones and at least 3 injectable second-line drugs. So that's kind of scary that we have extremely drug-resistant. So, if we don't watch before long, we're not going to have anything that's going to treat it. Again, just like we were talking about with HIV earlier, people think that it's okay just to stop taking their antibiotic because of, symptoms, like maybe they feel like they're better because they don't have their active symptoms anymore, or maybe they just don't want to take it because of side effects that they're having. So if that's the case, if they don't take it for the amount of time they're supposed to, they're not going to get rid of it, and then they're going to end up getting symptoms again, and they're going to come back in, and then they're going to have drug-resistant TB. So it's really difficult to get rid of this if you don't treat it the right way. And typically you're on your medications for like 6 to 9 months. So for this one, again, you would test someone for this by doing a skin test, a PPD, which we've all done before, in your upper arm, your inner arm here. So typically, if you do that, once you get your test, you have to go back and get it read within 48 hours. If that's positive, it doesn't necessarily mean that you have TB. So typically it just means that maybe you've been exposed to it at some time. So then they would follow up and do a chest x-ray. So then they would try and see if they see anything on that, and they would kind of go from there with that. So the best way to tell if someone has TB or not is to get a sputum culture. The sputum culture would actually test and tell you if they had it or not, for sure. But anyway, prompt treatment with multiple antimicrobial drugs is very important. So treatment failure may be due to lack of client adherence, which can result in drug resistance. Okay, so our role in providing preventative care for communicable diseases, again, prevention is really key. So that's one of the primary things we do. Try to educate people about how to avoid the infection altogether. For secondary, we want to do testing and counseling for HIV, partner notification and contact tracing. And then tertiary, we want to do directly observed therapy and always use standard precautions. So like some of the examples they give here with primary. So with your assessment, you want to assess their risk level, their sexual history, and their partner notification. Interventions would be education and other actions aimed at prevention. Sexual behavior, abstinence, condom use, female condoms. With drug use, tell people the danger of using shared needles and syringes. With community outreach, reach out to those who do not seek care on their own. With community education, you want to spread information about modes of transmission, testing, vaccine availability, and early symptoms. And then with evaluation, you want to determine whether adequate vaccination occurs, whether risky behavior changes have changed, or whether the illness is prevented. With secondary, we want to screen for disease to ensure early identification, treatment, and follow-up with contacts. And then tertiary, we're managing symptoms and maintaining psychosocial support. We're doing directly observed therapy programs for TB medication. And then, of course, we're doing our standard precautions, right? So hopefully a lot of that was just kind of, review for you from stuff that you've had before, I hope. So let's see if we can do some questions on that stuff. All right. A client newly diagnosed with HPV infection, herpes simplex virus 2 infection, and syphilis. Gee whiz. They ask, okay, so how do I get rid of all of this stuff? In developing a plan of care, the nurse recognizes that is essential to address. What would you want to address?
Part of me wants to say A, but I know they don't prevent all STDs. They just can. There's a barrier.
All right, let's see what it says. So it's supposed to be C. So risk of skin-to-skin contact and transmitting the identified STDs. Because, they have a few different things going on. So HPV, herpes, simplex, and syphilis all together. So a lot of these are skin-to-skin type contact. All right, let's look at this next one here. Okay, a nurse is assigned to teach clients STD prevention information. The nurse updates her teaching plan to incorporate new guidelines from the Centers for Disease Control and Prevention. She includes which of the following as updated information during her next teaching session.
Is it B?
It sure is. All right. A woman comes to the community health center complaining of increasing lower abdominal pain, fever, abnormal menses for several months. During the assessment, the client indicates that she's aware that her husband has had multiple sex partners in the past 2 years. Appropriate intervention by the nurse would be to do what? Page down without showing you the answer here. do
It's
you
C.
A. So it's saying arrange to have the client referred to for pelvic inflammatory disease. Huh. So down here it says nurses' assessment should always include taking comprehensive sexual history to determine potential risk for STDs. Each sexual partner is potentially exposed to all STDs of all persons with whom they've been sexually active. Pelvic inflammatory disease is a serious infection involving the fallopian tubes and the most common complication of gonorrhea, but it may also be a result from chlamydial infections. So it's those symptoms, I guess, is what we were supposed to pick out. So the fever, the abnormal menses, and lower abdominal pain. All right, how about, oh, let me go past that since I showed you the answer already. Okay, community health nurses conducting health education among populations vulnerable to HIV infection should explain the natural history of the infection, including the fact that HIV infection may go undetected during the primary infection stage because anyone have a guess?
B.
This is going to be A. So typically, someone could have a test for HIV and it might originally show up negative when it's really positive. So antibody test results are typically negative at first with them, even though they may already still have the disease. Okay. So anyway, I'll send this to you guys so you guys can take a look at that again. But all right, let's do something different real quick. I'm going to split you guys into two groups. I'm going to put you in these little breakout rooms. I don't know if you've ever done that before in these breakout rooms. And I have, oh, someone just left though. And anyway, I have two case studies. So I'm going to give one to one group, one to the other group, and I want you to work on them for a few minutes, and then we'll come back together and answer them, and then we'll get off here. So I'll probably give you like 15 minutes to look at it and answer the questions, and then we'll come back together and into this Zoom here. So let's see. Okay, so I opened up these rooms. You can go into the room. I'm going to send someone in your group an email to tell you what I want you to do. Okay? So go ahead and go into your rooms. I'll send you an email real fast with what you need to do.
inspector at the County Health Department. Nurse Hillary visits businesses in the community that have the potential to spread infectious diseases to large and or vulnerable populations. Today, Nurse Hillary will visit the We Love Kids Daycare Center and nearby seafood restaurant.
Did you guys get my email? I sent it to Erica, I believe. Did you hear me?
Yep, I got it.
Okay. I just want to make sure you got it. Okay. All right. I'll leave you guys be for a few minutes so you can get done.
Okay.
Did you have enough time to answer those or no?
We did.
Okay, perfect. All right, Erica, do you guys want to go first and tell us what you guys came up with? You guys had chapter 14 stuff, right?
Yes.
Is it this, what I have on the screen? Jill?
Yeah.
Okay, perfect.
Yes.
All right, so remember the other group doesn't have this one, so I don't know if you want to just read it real quick to everyone and then just tell us what you came up with.
Oh, I guess that's me.
Well, anyone in your group can, I don't care. I just want someone to read it, and then if someone else in your group wants to tell everyone what you guys came up with, that's fine.
Okay. Case study. Jill M. is the nurse epidemiologist for the Warren County Health Department. Part of Jill's role at the health department is to administer TB screening to at-risk populations and to track TB cases seen in the county. Nurse Jill has identified the homeless population in Warren County as the high-risk population for TB. Nurse Jill has already implemented a TB education program at the homeless shelter. Every other month, she goes to the shelter and teaches a class about TB, what it is, who is at risk, and why individuals should undergo TB screening. Furthermore, every person who wishes to stay at the shelter must submit to a TB screening test. Yesterday, the homeless shelter contacted Nurse Jill and reported that one of the men who was staying at the shelter tested positive for active TB, but shelter staff now cannot find him. The shelter director suspects that the man has left for work at one of the rural farms that offer temporary work, but he does not know which farm. Nurse Jill talks to the men at the shelter who spoke with the client. She learns that the client, Jose, is in his 30s and speaks only Spanish. The friends give Jill some leads about farms the client may have gone to. Nurse Jill calls the farms and speaks to the farm managers. Luckily, Jill discovers that one of the farm managers had recently gone to the shelter to recruit workers. Nurse Jill visits the farm and by interviewing the newly hired men, finds the missing active TB case. Because of his transient lifestyle, Nurse Jill decides to enroll the man in directly observed therapy, or DOT, for TB treatment. DOT will provide a hotel room and meals for the man while he receives TB treatment.
All right,
So
one of the first questions was, who is at risk for contracting TB from this client? So what did you guys say to that? And you don't have to answer it all. You can have someone else in your group say it.
I can answer it.
Okay.
We said that contact with is at risk for getting the TB from him. So everybody at the shelter, the people at the farm that he went to work at. What was the other one that we said? We said another one. I can't remember now.
So on this thing, I have it on the screen here. It just says TB is usually transmitted through exposure from that tuberculous bacilli and airborne droplets from persons with pulmonary TB, you know, when you're talking with them, coughing, sneezing, and they're in close proximity. Anyone who has had close contact with the person is at risk. So this means even if this guy like took a bus to this, you know, thing, like however he got there, if he, you know, hitched a ride with someone or whatever, those people would be even at risk. So anyone that came in contact with him. Okay, the next question was, what primary, secondary, and tertiary prevention interventions did Nurse Jill use to prevent the spread of TB?
Primary would be like screening. The secondary, maybe the education that she did every other month.
All right, so did you have anything else to say? I don't want to. Okay, so anyway, this just says that primary prevention would be the education classes at the shelter, because she's trying to prevent people from getting it and knowing how it's spread and all of that. Secondary would be the screenings, because the screenings are assuming that maybe someone already has it and you're trying to catch it before it gets worse and gets spread. Tertiary would be initiating that DOT, for that guy that has it already, so he doesn't keep spreading it to other people. Okay, so the last question was, what barriers to controlling TB did Nurse Jill encounter, and how did she overcome the barriers?
So, barriers controlling TB. I would say one, obviously, the language barrier between her and the person that had the active TB. Then obviously physically having to find that person. And then I would say another barrier would be knowing the storyline or like the timeline of who he actually came into contact with. So kind of trying to trace her steps as possible, or not her steps, but his steps best as possible, and kind of like linking the pieces together. Yeah. And then obviously she overcame the language barrier by contacting or talking with people from the farms and from obviously the farmer that could speak the language.
All right, and this is just saying barriers involve finding and treating the homeless man who does not have a permanent residence, because he's so transient. He's always moving around doing different things, so it's hard to find him. And then the language barrier, like you guys said. And then it says Nurse Jill overcomes these barriers by knowing how to speak Spanish, which I didn't know that it said that in the thing, but okay. And by being creative and tracking down the man by talking to his friends and his employer. So sometimes you kind of have to think on your feet to figure things out. So good job, guys. That was good. All right, so that's that one. And then we got one more. Okay, so the other group, someone read this to everyone. This is chapter 13.
Hillary S. is the nurse health inspector at the county health department. Nurse Hillary visits businesses in the community that have the potential to spread infectious diseases to large and or vulnerable populations. Today, Nurse Hillary will visit the We Love Kids Daycare Center and a nearby food restaurant. The daycare center cares for children ages 1 month to 6 years. To enroll a child in daycare, parents must show proof that the child is up to date on all age-appropriate immunizations or must show proof of medical or religious exemption. Nurse Hillary finds the records in the office area and confirms that all children have received the necessary immunizations. She observes that employees use gloves when changing diapers, cleaning a baby's spit up, and tending to a scratch knee from the playground accident. Employees also wash their hands after each one of these events, before and after giving a baby his bottle, and before entering the 1 to 6 month old room, and after leaving the 2 to 3 year old room. Nurse Hillary also notices a flyer in the employee break room that informs staff of the upcoming mandatory in-service that will be held to discuss the importance of checking bottles, especially those that contain breast milk, for the correct name before feeding the child. The seafood restaurant is a chain restaurant that has become less popular over the past couple of years. Many customers have complained about the quality of food. Recently, 20 cases of severe diarrhea were reported to the health department by the people who had just eaten at the restaurant. Nurse Hillary observes that the cooks in the kitchen, the refrigerator, and the freezer are kept at appropriate temperatures for storing food. Food is stored in an airtight plastic containers. Nurse Hillary watches at the cook who is preparing the chicken for broiling, is also in charge of prepping the plates that are going out to the customers. Upon cutting into a piece of chicken about to go out to the dining room, Nurse Hillary notices that the center looks pink and undercooked. Pieces of wilted lettuce are scattered on the countertops. During her 2-hour visit, the main chef washes his hands twice, although he leaves the kitchen 4 times for a smoke break.
All right, so the first question was, how is the daycare center providing infectious disease control? So what are some good things that they're doing?
So the daycare center is making sure that everyone's up to date on their shots or like has a legitimate excuse not to have them by a medical professional. They wear gloves when changing the babies. They wash their hands coming in and out of different rooms, and they have like the in service for the bottle checking.
All right. Describe the outbreak of diarrhea. Is it endemic, epidemic, or pandemic?
That one was the epidemic.
Okay. And then, which of the 5 keys to safer food does the restaurant not follow?
So they definitely aren't handling the food properly, like with the wilted lettuce just on the countertops, growing bacteria and stuff, and then people eating it, and then not cooking the chicken all the way through, so they're not having safe practices with that. And then obviously the hand washing is a huge problem if the main chef isn't washing his hands. So those are like probably the 3 biggest things that they can do better.
All right, good job, guys. So I just thought this would be a different way to kind of get some of the topics that we talked about today to kind of get it in your head a little bit more. So that's going to be everything for today. With your stuff, I got Delaney's email from her thing. So Drew, you just forward yours to me when we're done here so I can see what you have so far. And then don't forget with that paper, so like right now we're in week 6. So look at this timeline here. So really week 5 stuff should already be done too. So like I'm just now looking at your community history. So we should be also looking at statistical data already too. So the statistical data would be like, say you think that your city is having a big problem with opioid addiction or something, and then you would present to me in that paragraph all the statistical data about that you can find. So like there's probably different places that you could go to on the internet to find that stuff in the in the community. So it's probably public knowledge somewhere. So you can find that and then you write it in your paragraph and then you could give that to me as well. So next week, week 7, that's when you start doing the environmental sections of the community assessment. And that's kind of a big longer section, that you need to do. So just make sure you're staying on track with this, you guys. If you have a chance to work together on this during your community clinical, use it because there's a lot to do, okay? So give me what you have so far and then make sure you're working on the rest of this and like get it to me as soon as you can so we can kind of stay on good track with this, okay? Are you guys talking about the stuff with Mr. Smith at all or not?
Kind of.
Okay, I don't know if he's like asking to see any of your stuff or not, but just make sure if he is looking at it, I'm fine with that, but I just want one of us to be looking at it to make sure that you're staying on track is all I'm getting at, okay? All right, any questions about anything?
Nope.
All right. Well, you guys have a good afternoon. I will forward you an email, some of that stuff I was showing you. So we should be getting that in pretty soon.
Thank you.
All right, thanks guys.